Ultrasound application and scanning techniques. The interface of the ultrasound machine can be daunting. However different the machines may be, the concepts are the same. Understanding the concepts should be done prior to starting an ultrasound-based study or procedure. Finding each one of the knobs may be done during the case. The knobs or features are there. Ultrasound doesn't really change. User interface, knobology, a modern console machine. A digital interface ultrasound machine. Here we see a touchscreen machine. Here we see a very basic interface ultrasound machine. I don't see a knob here. This is a GE Vscan. Here's some more user interface. Gain. Adding this will increase the overall brightness of the picture. Decreasing this will cause the picture to be darker. The goal here is object contrast. Newer users will often add too much gain and miss important details of the scan. Gain is a receiving function, not a sending function of the ultrasound beam. Increasing the gain essentially makes the machine listen harder. Now you may hear the machine hum when increasing gain. However, this is the amplifier, not more beam power being produced, so you're not going to hurt the patient with increasing the gain. Many machines designed for point-of-care ultrasound, or POCUS, have a knob for overall gain, near-field gain, or Fresnel gain, and far-field gain, or Fraunhofer gain. This is a common POCUS ultrasound machine. This is a Sonosite Micromax. At the top we see the near-field gain, which is known as Fresnel field gain. In the middle we see the far-field gain, or Fraunhofer field gain. And at the bottom we see a knob for the total gain. Gain can also be broken down into segments of the axial dimensions of the ultrasound beam. When broken down into small zones, gain is referred to as time gain control or spatial control gain. These knobs look like graphic equalizers on an old hi-fi stereo. What the heck is that? Here we see a Chison desktop machine with an overall gain knob in yellow and an STC or spatial time compensation gain sliders on the right hand side of the screen. Different manufacturers may use different terminology. The TGC are typically set for the maximal parameters of the ultrasound machine itself. Rarely in anesthesia do we use probes capable of scanning such depth. With shallower probes, the user may have only 2 or 3 sliders in field. Here on the STC, we see a common strategy to optimize the image, and this is by decreasing the gain in the near field and increasing the gain in the far field. Things will naturally be brighter in the near field. Dynamic range. Although not available for user interface on all machines, all ultrasound machines do have dynamic range. DR is a function of contrast and basically determines how white is white and how black is black. Typically, maximal DR should be used for best image quality. However, in areas where low-level reflectors, noise, or artifact confuse the picture, it should be reduced. As an example, when placing a MAC catheter in an obese patient at, say, a depth of about approximately 4 centimeters or more, reducing the DR will make the vein stand out. This is because you have a lot of varying shades of white that are all very similar, but obviously very different structures. So decreasing the DR is actually going to help increase your chance of success. The same can hold true with an adductor canal block in a patient that has either like tissue or is very obese. Focal zones. The focal zone is the area with the highest lateral resolution. The focal zone indicator on the ultrasound screen is seen here on the right. Set the focal zone to the region of interest. Here we see the focal zone set to just above the region of interest. On static scans such as a central line or regional block, consider the use of multiple focal zones when possible. Avoid using more focal zones than needed. Also, multiple focal zones should be avoided on moving structures such as during a TTE, which is a transthoracic echo, or a transesophageal echo or TEE. Increasing the FZs may decrease the frame rate, hindering temporal resolution. How many focal zones did this machine have? This is Tom Brown's auto scanner from the 1940s. Depth. Although easy to understand, proper use is important. Use the depth level required to safely perform your procedure. Use the shallowest depth possible. Increasing depth will decrease the width of the image. THI is tissue harmonic imaging. The knob may also read on different machines HARM or HI. Seen on most newer machines, this function can increase image quality. It sets a different listening frequency from the sending frequency. THI is then able to tell what sound is reflected back from the ultrasound beam and what sound is being produced from the tissue. The listening frequency is typically twice that of the sending frequency. So, if you're using a 5 MHz probe, it will listen at about 10 MHz. THI may not be beneficial in the extreme near or far field. As always, the resolution may be increased at a cost of frame rate and decreased temporal resolution or resolution over time. Auto-optimize can be a useful setting or starting point, especially if the machine is a shared services machine. After using the auto-optimization feature, auto-tune, tissue equalization, or AI, the image can be further processed by the user. Freeze. This is a valuable feature that is great for interrogation of an image by providers and students. The Cine can be used to look at frames prior to freezing the frame. This is a very useful feature when doing a TEE. I frequently have multiple people watching a procedure at my teaching facility, and freezing is very useful along with the Cine loop to show what's going on with either the scan or the procedure. Calipers. When you encounter a structure that needs to be measured, freeze the frame and use the calipers. This will give useful information when consulting other healthcare providers. Successful scanning. Two possibilities of probe orientation exist. Out of plane is often used for vascular access. Visualization of two lateral objects is possible. The needle, however, can only be seen for as thick as the beam is. This is the property of the beam elevation. Here we see the beam elevation or thickness. Here we see the out of plane orientation of the needle and the probe. Needle tip control out of plane. The tip of the needle is the desired view by the anesthesia provider. Frequently, the procedures in anesthesia, such as central line insertion, require visualization of two structures simultaneously. Due to slice thickness or elevation, we only see about 1 millimeter's worth of the needle. So here we see the approximation of a needle out of plane. But where's the tip? We don't know right now if we're looking at the tip or the shaft or what part of the shaft we're currently viewing, because we are only seeing the needle for as thick as the beam slice is.
Great, welcome back. So what I'm going to do now is practice out of plane technique, and I want you practicing along with me. So I'm going to go ahead and take the probe in my non-dominant hand. For me, it's my left hand. I'm going to go ahead and put gel on the ultrasound probe. And I'll notice when I do that there's a little notch on the side of the probe. It's only on the one side. Now this notch correlates with the dot on the screen. Depending on the manufacturer of ultrasound machine, it could be a dot, it could be a logo of the company, or it could be a letter. So I'm going to go ahead and take that probe with my non-dominant hand, and I'm going to find the vascular structure. Now we typically use ultrasound in the out of plane technique when we're using it for vascular access. So I'm going to go ahead and take the vascular item and put it in the center. Now there's a large one and a small one, the small one being the artery, the large one being the vein. It doesn't matter which one you pick. We're just practicing. I'm going to go ahead and with my dominant hand put the needle in to the skin of the gel, if you will. And I'm going to watch it go into the structure as I advance it. So go ahead and advance your needle. And we're going to go all the way down until we feel it pop through the vessel. And there it is right there. Now if you noticed, you only saw the needle for a split second as it went through the curtain of ultrasound sound itself. So you only see that little hyperechoic orb as the needle passes through the probe. Now, what I want to do is be able to see the needle the entire way down. So what I'm going to do now is, again, I'm going to center my vascular structure. So go ahead and do that right now. And I'm going to take my needle. This time I'm going to put it very close to the probe. Again, directly in the middle. So middle lines up with middle on the screen. Now, in the near field, or the very top of the screen, I see an orb. Now I'm going to advance my dominant hand with the needle at the same time as sliding my non-dominant hand distally. And I'm going to keep that orb in view. And it's going to go all the way down until we get to the vascular structure. And I can see it right there, and I'm just going to go ahead and poke right through that. So that's our out of plane technique that we typically use for vascular access.
So for successful scanning, we can also use the in-plane technique. Often used for ultrasound-guided regional anesthesia, or UGRA, this offers a good view of the needle during the approximation stage of the block. Here's a picture showing the in-plane technique during a supraclavicular block. In-plane technique. We see the needle during the entire process of approximation during an in-plane axillary block.
I'm going to go ahead now and switch over to our in-plane technique. Our in-plane technique we typically use for regional anesthesia or anytime you need to see the needle path the entire course. So go ahead and take your non-dominant hand. We're going to go to the other side of the target and we're going to find our hyperechoic or bright nervous structure. So I see the nervous structure right there. Now what I'm going to do is I'm going to go ahead and rotate the probe 90 degrees towards me. And I'm going to keep that item in view. Not always so easy because the item's only 1 millimeter or 2 wide. So there's our hyperechoic nerve. And I'll notice that the notch is facing me. So as the notch faces me, I know that my needle is going to enter from the dot side of the screen. So I'm going to go ahead and put the needle in about 1 centimeter away from the probe. And there, I see it in the near field or the top part of the screen. I'm going to go ahead and advance it all the way down until I feel the nervous structure. There it is. And you should actually be able to feel it with your right hand. So that
There are 6 steps to reproducible ultrasound-guided procedures. After practicing these steps, they become second nature. They are similar to the 6 P's if you're familiar. The 6 steps: preparation, visualization, approximation, interrogation, deposition, and evaluation. Failure during any one of these steps could have a detrimental impact to the success of UGRA. Preparation involves having the patient, monitors, and equipment in optimal location. Have all equipment within reach. Place all supplies including sterile gel in position, then cover the probe. Visualization. Utilize the scanning techniques: sliding, angling, rotating, tilting, and using pressure. Visualize the target in its best anatomic location. Slight movements, typically sliding, are all that are normally required to view the needle. This graphic demonstrates sliding, angling, rotating, tilting, and the use of pressure. Approximation involves how to best bring the needle to the nerve or structure of interest. In-plane offers better needle visualization but may cause more discomfort, especially in, say, interscaling block. Out-of-plane technique is useful for superficial structures and vessels. The needle, however, only appears as a hyperechoic sphere. Interrogation. The use of a nerve stimulator to confirm correct placement. I still use this. With proper picture, experience, and device, this is rarely necessary. It's very useful, however, when learning blocks or teaching the anatomy of the blocks. I still use a nerve stim mainly because you are applying what you see in a 2-dimension scan. In reality, it's actually a 3-dimensional body. So when interrogating your nerve block quality, you can use a nerve stim and find the motor responses for each nerve. There's the median nerve motor response, the ulnar nerve motor response, the radial nerve motor response, and the musculocutaneous, of course. However, all 3 of these, the median, the ulnar, and the radial, look pretty much the same. The one that looks mainly different clinically is going to be the musculocutaneous. So deposition. This is the deposition of local anesthetic. This is used to verify the correct target has been localized. An in-plane approach is going to be needed. Often the nerve is seen as a hyperechoic structure floating in hypoechoic local. The visualization of hypoechoic local also verifies that you're not intravascular with your injection. Other blocks fill a fascial boundary, causing a donut sign. Now we're going to go ahead and evaluate our block. We're going to reassess the block to see if it was complete, partial, or failed. Keep in mind that some blocks will take up to 20 minutes to set up or fully take full effect. Consider these pearls to enhance the safety of a nerve block. Ensure complete needle visualization while advancing the needle. Direct the target to the top, bottom, or side of neural targets, as opposed to directly into the middle of the nerve. Slightly withdraw needle from the nerve prior to injection. and you can utilize hydrodissection with local or other fluid to visualize the tip. A quick way we can assess the brachial plexus is with push, pull, pinch, pinch. First, we will have the patient push their forearm against light resistance to test the radial nerve. They will then pull or flex their arm towards their nose with light resistance. This will test the musculocutaneous nerve. We're going to then test the median nerve by pinching the thumb. We will then test the ulnar nerve by pinching the pinky. We're going to go over some basic maintenance of the probe. Now, prior to use, ensure you have selected the correct probe, whether it's linear, curved, or phased. Ensure the probe is clean. Most probes can be cleaned with water. After each patient contact, the probe needs to be cleaned in accordance with AIUM guidelines. You can go on AIUM.org for more information. External probes are considered non-critical devices and require cleaning after each use. Cleaning needs to be followed by low-level disinfection. This disinfection may not kill Mycobacterium tuberculosis or bacterial spores. The probe does not need to be sterilized. Keyboards need to be cleaned as well. Typically, the cleaning of the probe can be done under running water. The American College of Radiology and the AIUM, the American Institute of Ultrasound and Medicine, both recommend a quality control program. It is advisable to carry out basic testing during the acceptance of new equipment, both probes and scanners. The next video will give you some tips in a non-comprehensive provider level test.
Okay, I'm going to be demonstrating for you a quick test that you can do on your ultrasound machine to test for the quality of the probe. This test in no way is going to replace a full acoustic spectrometry test of the probe. That's typically done by either biomedical or a biomedical physicist in medicine. So what we're going to do first is we're going to take our probe. In this case, it's about a 7.5 megahertz linear array probe used for POCUS, point of care anesthesia. I'm going to go ahead and turn my gain of my machine up to see the ring down come. Now, as I look at the bottom or the far field of the ring down, I'm looking for any discrepancies or unevenness. This could indicate damage to the lens. Okay. Next thing I'm going to do is I'm going to take a key and I'm going to look for weak elements. Now, as I can see already, I have a little bit of shadowing going on. And what I'm going to do is I'm going to take the flat end of this key and I'm going to go ahead and I'm going to swipe it across gently. We don't want to scratch that lens. Now, as I'm doing this, I'm seeing some areas have some weakness or some shadowing. It looks like shadowing artifact. That's going to indicate a possible weak or dead element. Now, this basic test should be performed anytime you take a machine either out of storage or a probe out of storage. It might be that probe that you never use if you had multiple probes on your POCUS machine, or anytime you take a new purchase of equipment. It could be new equipment, it could be refurbished equipment. You want to check it out and see what you got. Now, as you saw, we had some weak elements there, but that on this particular machine doesn't make much of an imaging quality issue for me for the type of exams I perform. I'm now going to be taking a look at another probe just to demonstrate the difference between two different probes. Again, this is another POCUS or point of care anesthesia type linear array probe. It's a 7.5 linear array probe. I'm going to take a look at it to compare it to the last probe. Again, I'm going to make sure there's no coupling agent or gel on the lens. I can always wipe that off. I'm going to go ahead and turn the gain up so I can see ring down. I'm going to check for errors with the lens in the far field. I'm going to then take my key and gently place it on, again with the flat end only, not a jagged key. I'm going to go ahead and start from one side and observe the ring down. And I'm looking for any kind of shadowing. Shadowing could indicate a weak element or a faulty element. And as I see, this probe is in pretty good shape. That's because I just bought it and I've had it since it was built. If you have any questions or comments, give me a call, an email, and thank you for watching.
If you need to start a basic maintenance program, this form is available from the American College of Radiology.